Hey everyone, welcome to this explainer on retinal anatomy and histology. I'm absolutely thrilled to have you here. If you're a resident preparing for the OCAPs, or a med student stepping into the ophthalmology clinic for the first time, you probably know that the retina can sometimes feel like an overwhelming alphabet soup of layers and cells. But today, we're taking a completely different approach. As a residency program director, my goal for you is long-term clinical mastery, not just short-term memorization. By the end of this, you won't just be memorizing isolated facts. You're going to understand the why behind the anatomy and exactly how microscopic histology translates directly to the OCT scans you read every single day in the clinic. We're going to connect the dots from physiology to pathology. Okay, let's dive into this. All right, let's look at our roadmap for today. We'll start micro and move to macro. We're going to cover 1. Defining the neurosensory retina, 2. Retinal cells and pathways, 3. Photoreceptor anatomy and function, 4. Translating histology to OCT, and 5. Some high-yield clinical correlates. Building this mental scaffold right now is going to save you a massive amount of cognitive load later on. So let's get into it. Section 1. Defining the neurosensory retina. To kick things off, I want to start with an active recall prompt to get you thinking like a clinician right out of the gate. So, here's the question. What is the exact difference between the retina and the neurosensory retina? Imagine we're in clinic right now, and I just asked you this. What is your definitive answer? I want you to pause for a second, actually force yourself to retrieve this from your memory, and silently lock in your answer before we move forward. Got it? Okay, here's the answer. And honestly, this is a classic board trap. The neurosensory retina is strictly the neural lining on the inside of the eye. But the retina? That's the neural lining plus the retinal pigment epithelium, or RPE. Do not confuse these two on your written boards. Including or excluding the RPE literally changes the entire anatomical definition. And, why does this matter clinically? Well, when a patient gets a retinal detachment, the RPE actually stays securely attached to the choroid while the neural tissue peels away. So pathophysiologically speaking, you're actually looking at a neurosensory retinal detachment. Moving right along to Section 2, retinal cells and pathways. Now that we've got our definitions perfectly straight, let's break down the cellular taxonomy of this tissue. You absolutely have to commit this structural list to memory, but let's do it with a mental model instead of just rote memorization. The neurosensory retina has 3 broad classes of cells. First, we have 5 types of neural elements. Think of your vertical signaling chain first, photoreceptors to bipolar cells to ganglion cells. Then, add you 2 horizontal modulators, amacrine and horizontal cells. Next up, we have 3 types of glial cells, Mueller cells, astrocytes, and microglia. And finally, the 2 vascular cell types, endothelial cells and pericytes. This is a fundamental OCAP breakdown. Just remember the 5-3-2 rule here, and you'll be golden. Now, what's really fascinating on this slide is the Mueller cell. Take a close look at this diagram. The Mueller cell is this massive glial component that physically spans the entire breadth of the neurosensory retina. Notice the base of the cell up at the top of the image. Its foot processes literally fuse together to biologically create the internal limiting membrane, or ILM. Let's put on our clinical thinking caps for a second. When you're in the OR doing a macular hole repair and you reach in with your intraocular forceps to peel the ILM, you're physically interacting with and stripping away the foot plates of these exact Mueller cells. It's wild to think about, right? Anatomy dictates surgery. Let's conceptualize how these neural cells actually talk to each other. We divide them into 2 pathways. Think of the vertical pathway as the express highway straight to the brain. Photoreceptors pass the signal to bipolar cells, which pass it right to ganglion cells, and boom, off to the visual cortex it goes. In contrast, the horizontal pathway relies on amacrine and horizontal cells. These are inner neurons. They're kind of like the local traffic cops. They don't send signals to the brain. Instead, they conduct impulses from one local area of the retina to another to modulate, inhibit, and really refine the flow of information before it ever hits that express highway. Next up is Section 3, photoreceptor anatomy and function. We really need to drill down specifically on the photoreceptors because this is where phototransduction begins and, frankly, where a massive amount of board questions come from. You all know about rods and cones, but let's lock in the numbers and the physiological why behind them. You've got about 100 to 125 million rods per retina, and these are responsible for monochromatic low-light vision. Conversely, you only have 6 to 7 million cones, which are highly concentrated in the macula for color and sharp acuity. But why do we need so many more rods? Well, because in the dark, you desperately need spatial summation. Multiple rods have to converge onto a single bipolar cell just to detect a single faint photon of light. So you're sacrificing visual acuity in exchange for extreme light sensitivity. Look closely at the morphology here. I want you to focus on the outer segments at the bottom, where the discs containing rhodopsin are located. This right here is where the magic of phototransduction actually happens. Now get ready for a massive OCAP pearl. Look at how the photoreceptor outer segments interdigitate with the RPE cells below them. Notice anything missing? There are no direct structural connections or firm junctions holding them together. This creates a potential space. And why is that? Because the RPE needs to constantly phagocytose the shed outer segment discs. If they were firmly cemented together, this daily metabolic turnover would be literally impossible. So when a patient gets a rhegmatogenous retinal detachment, fluid easily pries apart this exact potential space. Just above that outer segment is the inner segment, which is divided into two absolutely vital metabolic zones. The ellipsoid is immediately adjacent to the connecting cilium, and the myoid sits just above it. So how do you remember which is which on the boards? Use this mnemonic. Ellipsoid is packed with energy-producing mitochondria. E for ellipsoid, E for energy. Myoid makes proteins and stores glycogen. M for myoid, M4 makes proteins. Keep the energy-rich ellipsoid and the protein-making myoid securely in your mind, because we're about to see them on imaging. That brings us right into Section 4, translating histology to OCT. We're going to connect the microscopic anatomy we just built directly to the macroscopic optical coherence tomography scans you evaluate every single day. Okay, so the absolutely crucial point is this quote right here. Read it carefully. OCT bands are determined by differences in tissue reflectivity, but differences in reflectivity don't necessarily correlate one-to-one with retinal anatomy. Think of OCT like sonar or an ultrasound of the eye, but using light instead of sound. It doesn't care about the histologic name of the cell. It only cares about the density of the structures it hits. Remember how the ellipsoid and the myoid are both parts of the exact same inner segment? Well, to an OCT laser, densely packed mitochondria reflect light very differently than glycogen. Therefore, they appear as radically different bands. The OCT is under zero obligation to see the retina the way a microscope does. Let's build our OCT map, starting from the outside and working our way in. Command your attention to the outermost heavy white line on this scan. This is the RPE/Brooks membrane complex. Whenever you look at a scan, find this line first. It is your foundational anatomical anchor point. But why is it so brilliantly hyperreflective? Because the RPE is absolutely packed with highly reflective melanin pigment. That physical density bounces the light straight back to the machine. So if you ever lose your bearings on a complex scan, always go back to the RPE/Brooks complex. Moving slightly inward, we find the ellipsoid zone, or EZ. And this brilliantly illustrates what we just talked about. See that bright, heavy white band just above the RPE? That hyperreflectivity is being generated by that dense band of energy-producing mitochondria. Imagine a patient presents to your clinic with 2200 vision after staring directly at a solar eclipse. You look at their OCT. The RPE is fully intact, but this specific ellipsoid zone line is missing right at the fovea. You now know exactly where the phototoxicity occurred at a cellular level. Assessing the integrity of the ellipsoid zone is absolutely mandatory for outer retinal diseases. Finally, just inside the dark band of the myoid zone, we see a very thin, delicate white band. This is the external limiting membrane, or ELM. Finding the RPE, the EZ, and the ELM completes our high-yield image recognition review of the outer retinal bands. Let's do a quick pop quiz right here to lock this in. From the inside of the eye moving to the outside, what is the anatomical order of these three hyperreflective bands? Think about it for a second. The answer? ELM first, then EZ, then the RPE at the base. If you can reliably spot these three lines on a scan, you are already way ahead of the game. Let's wrap things up with Section 5, high-yield clinical correlates. Let's tie all of these normal anatomical concepts directly into the specific pathologies you're going to face on the boards and while on call. Take a look at this beautiful end-face OCT angiography showing the deep retinal vasculature. This right here is a classic OCAP presentation. They'll show you an image like this and ask for the diagnosis. Remember the rule. The neurosensory retina has inner vessels, but the outer retina, the photoreceptors, they're supposed to be completely dark and avascular. They get their blood supply from the choroid below. So if you ever see an abnormal vascular network lighting up in the deep outer retina on an OCTA, you are highly likely looking at a choroidal neovascular membrane, or CNVM, breaking through. This is classic for wet, age-related macular degeneration. A vascular tissue that lights up equals CNVM until proven otherwise.
Let's move to our last image and see how this builds our clinical exam skills. This shows Hen's layer on an OCT. Hen's layer consists of the axonal processes of the photoreceptors diving obliquely into the outer plexiform layer. Now for a clinical mic drop, why exactly does a macular star form? Well, the anatomical fibers of Hen's layer radiate outward from the fovea, exactly like spokes on a wheel. So when lipid exudate leaks from microaneurysms, it tracks perfectly down these oblique axonal spokes. Clinically, this creates that classic appearance of a macular star that you see with your 78 diopter lens. The OCT finding and the clinical exam finding look completely different, but they are driven by the exact same cellular architecture. How cool is that?
Before you go, let's do a rapid-fire review. Remember your 3 core takeaways. Number 1, the RPE is not part of the neurosensory retina. Number 2, the ellipsoid zone shines bright on OCT specifically because of mitochondria. And number 3, if you see vessels in the outer retina on OCTA, it means a CNVM is present. I'll leave you with this provocative question. When you look at your next OCT in clinic tomorrow morning, are you just going to see a bunch of gray and white lines? Or will you see the underlying cellular physiology, the mitochondria, the glial cells, and the potential pathways that are actively driving the disease process? Thank you so much for joining me on this explainer. Use these mental models on your next patient, and I will see you next time.